So the first one is a talk by Dr. Mark Tann, who's a physician from the Indiana University. He got his MD from Ben Gurion University of the Negev Medical School in Israel. He later completed his diagnostic radiology residency at Bnai Zion Medical Center in Haifa. And his subspecialties include abdominal radiology and nuclear medicine. He's been in the field for a few years now, and he has helped tremendously with all his clinical work and research efforts. Because of the change in the schedule, Dr. Tann and Dr. Snyder will have a few extra minutes. After each talk, because of the logistics of CAGLA, we will get some questions, and then we might have if time permits, we're going to have a panel discussion with additional questions at the end. Dr. Tann?
Okay, well, thanks everyone for showing up. Very kind. I'm not sure, so do we have mostly radonc in the audience? How many radoncs are in the audience? One. Physics? 100%. And other people? Like medical or what? Clinical trials. Okay, excellent. I'm just trying to aim well. Let's say, is this the laser? Yes. Does this move slides? That worked well. Is it the other way? I got it. Okay, so disclosures, nothing relevant for this chat. Okay, so over the next 30 minutes, because I don't think anyone should have to listen to me for longer than that without medical care, we're going to be talking about 9 subjects. I'm not sure how many we'll get through, but I'll do my best. And it has, the first one is why molecular nuclear imaging? Basically, the answer is virtual pathology. And that has to do a little with the chat that the guy gave over morning, why someone thinks that blood-based liquid assays are going to answer all our questions for oncology. The next thing we're going to be chatting about is theranostics versus radiotheranostics. Theranostics is a cool word that it's a buzzword that everybody says, but I think it needs better clarification. New imaging technologies and how are these affecting how we do our theranostics? What are our milestones? Why is it such $1 billion? I'm not sure I'm going to compete with the oncology companies outside, but I think our competition is going to get a little stiffer over the next coming years. What can we do to improve the radiotheranostics? Where are we now? Where do we need to be? Can we be there? So we're going to be talking about personalized therapies and why we need physics, since I got a couple of physics people. Heterogeneity of tumor, why we kind of ignore that in America, why the Australians don't seem to ignore that and seem to do much better. How can we improve our radiotheranostics? Basically, there's a whole world of alpha therapies out there. I come from Indiana, which is a relatively small flyover state, but I have 19 new companies that have set up with LINAC accelerators to make me alpha emitters and beta emitters. Well, why would they do that if there's no market? Where else were we? Improving, better targeting, nanobodies, vesicles, small ligands, where should we be? And the last one is combination therapies. Maybe the world of oncology and radiation therapy and nuclear should all combine, which is probably no big surprise and will get better outcomes. Okay, so imaging cancer is pretty hard because of heterogeneity. That means that, so here's a picture, the picture on the bottom is a patient who has metastatic renal cell. If we go the hard route and do excisional biopsy, you're going to find 5 different types of genetic variations, and depending where you biopsied, you'll get a different idea and you'll probably come up with different drugs. Number two, if we look at the pictures above, here's a CT scan, and if I tell you on each of these images the patient has cancer, and you don't know that, so how can you manage this patient? So imaging cancer is hard. If it was that easy, we'd have done a much better job. I would say the parking lot in my hospital will be much emptier, but perhaps we can do a little better. So my learned colleague, who, by the way, has the company that sponsors this talk that we should be grateful for his breakfast, said that we can probably do an awful lot with tissue biopsies, liquid biopsies, which is a great idea. However, it's not going to tell us where the source of the biomarker is. Okay, you've got a cancer gene. All right, where what? Now what? And probably all of us, I would say 50% of the population that have gray beards probably have prostate cancer cells, thyroid cancer cells. Probably today, I think the CT is the yield of the physical exam. I think we've moved on from there, but I'll get in trouble with regulators. And the bone met, maybe if you're really good, you would pick it up, but I don't think you'd pick it up. I would have missed it. So all these three patients where I missed on the CT, we did a PET scan, we found them in each case. And I'm asking myself, why am I doing CTs? What's the point? I'm not contributing anything to anybody. I'm making a good living. Radiology in this country does well, but it didn't feel to be very meaningful. So as my narrative, I think this is where we should be moving. Okay, cancer heterogeneity. So I didn't know if I was talking about endocrine, pancreas, or prostate today. So this is just an example of heterogeneity while it's important. So this is an FDG PET scan. Does anybody not know what a PET scan is in the audience? Or anyone's too embarrassed to put up their hand? All right, anyway, it's a fancy exam where I can inject a specific radioactive tracer and localize and characterize what's going on in the disease. So this is a simple, two available off-the-shelf agents, no IND, no effort in a lab. I can just buy them. And this is what we should be probably be doing on every single neuroendocrine patient, but we're not doing it because it's easier not to do it. So here's an example. Also, does anybody treat people here with neuroendocrine disease? I didn't think this was the right meeting. But us as radiologists, we have a problem that we know that all these tumors grow a millimeter or two every year. So to say, impression number one, growth of disease indicating progression, that causes so much chaos because everybody goes to their doctor and wants to get treated and overtreated. So we shouldn't really say if it's significant progression, that would be meaningful. But minimal progression is kind of meaningless. And we've got fancier studies than CT. So we did, everybody usually just gets the regular dotatate somatostatin scan, which is really good for finding low-grade disease, which will not progress, where probably if you find it, the risk of treating the patient is probably higher than doing nothing. But it's a good study. We can find disease. But if we want to do a better job, we need to probably do an FDG scan and identify those lesions which will be the driver of the patient's mortality and morbidity, just to detect all lesions and if we try to treat all lesions, we're going to harm a patient. If we can just focus on the lesions that are going to cause problems, perhaps we may end up helping someone. And here's an Australian study. I don't know why I'm so jealous of them, but they did a really good job. That if you have lesions which are both dotatate and FDG, and you have a discrepance, obviously you have tumor heterogeneity. You're not going to do very well. So this is a group we should treat. However, we end up treating the group that usually have homogeneous, lots of dotatate only, which we can discuss what is our yield and when we should treat those groups. So heterogeneity is important. How can I test for that? Does anyone here do biopsies or know nobody likes getting their liver stuck. And I know as a radiologist, you ask me to biopsy someone's liver, I'm not going to find the right lesion, I'm going to find the easiest lesion. And that goes for breast cancer, lung cancer. It's hard to do it. Nobody wants to have a bleeding patient or have a complication. We go for the easiest lesion, but that easiest lesion is not the most, usually, you can't even tell if it's the most aggressive. Will that lesion be the driver of the patient's mortality, morbidity? If you didn't biopsy it, then we have to find some other way of characterizing what's going on. So I kind of like this easy combination that we can do in thyroid, we can do it in prostate, we can do it in most tumors to identify the discrepant lesion. Okay, should you be worried that we're not going to be able to help anybody in this room? So if you had infinite resources like a hospital that rhymes with MSK in New York, this is my toolbox. If you belong to a specific hospital and can afford it, there's basically no tumor that I can't identify with an antibody, nanobody, small vesicle, track it, characterize it, and then turn around and treat it. So the future is pretty good, theoretically, that I can identify most cell types, as opposed to the liquid biopsies, even the use of RNA. We're still, okay, you have a tumor somewhere. All right, great. This way we can be a lot more specific, but not everybody has this tool set. If I would ask my colleague from New Orleans, you'd probably have 2 or 3 of these. But the more money is invested, I think some of these will make it through the economic threshold. Why else is, I think, the future of radiotheranostics or theranostics assured? So, as I said before, I come from a small state in Indiana, and out of this 32 companies which are in the theranostics business, who are putting about $8 to $9 billion a year in research and investment, I have the majority of this circle in one little state represented all around our airport, not because of me, because of our FedEx hub, but that just kind of tells you that people are thinking that it does offer solutions that before. And if enough money is invested in it, probably will have good outcomes. We can see what's happened in the prostate cancer therapy. But we're in billions here. We treat about 20 patients a week. And that's pretty high for most places. And we're only getting about 30% of what exists in the state. So even a place here in Louisiana would probably do quite well. So it's a large market. And people are investing in this market, so it's nice to be ahead of it. Okay. What else has happened that's made the kind of the revolution? Our scanners have got bigger. If you remember CT scanners, when I started, we had a single scanner, and you would wait half an hour between each slice, and it was great to be a radiologist. You would read 4 studies a day. Life was brilliant. Now we have, I think, the average scanner size on a CT is 256. So that's 75 seconds for a 2-meter patient. And that is 75 seconds. It's about 40 patients an hour you can push out. Nobody can read that fast. I can't read that fast. AI will help. But the same type of resolution has actually happened in PET scanners. There's a negative aspect of it that I'll have a lot more cases to read. There's a positive that I'm doing a much better job of sensitivity. So if you'd asked me 5 years ago, could I label an antibody to a specific tumor? And 30 days after labeling an antibody, could I detect it? Or can I do imaging of stem cells or cancer cells and monitor them for 30 days? So we have an agent called zirconium, if anyone's heard. It's one of our long-lived PET agents, which we use for antibody imaging, or if I want to do cell labeling. And the cameras now are so sensitive that I can track things for a long period of time. And the scan, instead of, I remember when I started in 98, maybe 4 hours a scan, we're down now to 7 minutes a scan. So even kids, we don't do sedation like we used to do for these type of scans. So I recently was chatting with our children's hospital and saying, if you reduce the cost of anesthesiology for every imaging study, I can translate that into a faster scanner and that'll work. And for a change, someone actually believed me, and we've got one of these for our pediatric hospital. What else has changed? Does anybody know what a SPECT camera is? 1. Okay, we're doing well. So a PET camera is where we look at positron or PET imaging. But this camera has also caused a revolution for our physicists, that this is a different type of camera that measures a different type of energy, mostly gamma. And this we can do after each therapy. We can take a picture of our patient, whether I gave him Y90, whether I gave him lutetium, whether I gave him an alpha emitter. And I can measure how much of my dose, instead of here's 6 doses of therapy, chat with you in 6 months. After each time point, I can see where I gave, how much went to the bone marrow, how much went to the kidneys, did I reach my critical target per lesion, and I can modify my doses each way. We didn't used to be able to do that. So what's happened here is our SPECT scanner from 40 minutes has turned to 6 minutes for a patient. So they get their injection 4 hours after their injection of PSMA or Lutathera. They hop on the bed, and I work out, did they hit tumor targeting? Yes, no. Do I need to up the next dose? Are the kidneys getting too hot? Is the bone marrow? So these patients, especially with low-grade neuroendocrine, are going to live 20 years. Apart from getting paid for each dose, there's no point destroying their kidneys or bone marrow in 4 years' time. So the ability to now modify it, and we're learning lessons from radiation oncology, we can do a better job, but unfortunately it takes more expensive equipment. But you're making so much more money. Like no one's ever asked me, this year I was told, what does the Theranostic building look like? How many floors do I need? I've never had a hospital ask me, what building would I actually want? Because I'm moving from a cost loser, which is radiology, to actually generating, having patients come in. So I can basically pick any toy that I want, which is kind of fun. All right, so let's clear up some concepts. Theranostics, an often malaligned used word, versus radiotheranostics. So what is this key buzzword, which probably I'm the only person that thinks it's a key buzzword because I hear it every day. So you put the word diagnostics together with therapeutics, and then you think you've made something new and you can buzz it and sell it. But it's been around a long time. The idea is, here's a group of people with a cancer. We're going to eliminate from this group these that have, this could be with, this is with an imaging agent, it could be with a tissue biopsy. If you have this particular marker, I'm going to treat you based on it. And if you don't have the marker, I'm not going to change my therapy. So if we look at this kind of busy slide over here, here's a bone scan. I don't know why we do bone scans. It's a mystery to me. I've never quite understood a bone scan. It doesn't image tumor. It images reforming bone. But we've been doing it for a while. It's tradition, probably like wearing ties or jackets. I have no clue why we do it, but we still do it. And it's still standard of care. Okay, FDG. So this is a patient with prostate cancer. The old method, do a bone scan and think you've actually achieved something. The new method would be just do a PET scan and see are there any aggressive lesions. And this has been around for years, but it didn't make it past the commercial threshold, doing an androgen test. I want to know on everybody that I'm going to be giving an anti-androgen, are the lesions more avid on a PET scan or an androgen test? There's no point giving someone if the lesions aren't avid on the androgen. Why would I be castration? If I was going to say I'm going to cut off your testicles and hopefully this may work, it may cause, in certain countries, some problems, but here, well, we'll just give them Lupron and maybe it'll work. We'll cross my fingers. It may work. It's going to make you miserable anyway. But this has been around for years and years that we could do this. Why don't we do it? Because, I don't know, more effort, and usually the antigen works, and who really cares if a 65-year-old doesn't have any testosterone? But we can do better, and this is a way of theranostics. So if this patient, I can see all the lesions in his body are androgen positive, I know for this patient, there's no need to be more aggressive than giving him an anti-androgen agent. And I've been able to do this since 2005, but you can see it doesn't ring a bell with everybody. We just give him it and hope for the best, because usually it works. Radiotheranostics. Oh, this isn't my latest slide, but anyway. What's radiotheranostics? I'm going to use the same agent that I use, the same detecting agent. This could be a somatostatin receptor to also treat you. So here's a patient where we selected from this group these that have either PSMA or, let's say, somatostatin if it's neuroendocrine, PSMA if it's prostate. If we think they belong to this group, I'm going to change isotopes from an imaging isotope to a killing to a therapeutic isotope. I used to be limited to Y90 or lutetium. I now have, in the state of Indiana, 9 therapeutic alpha particles, which I didn't think that last year I would have 1. If anyone's heard of actinium or terbium, I didn't hear of these till about 3 years ago. But basically, higher lethality, less toxicity, better targeting. So if I identify that you have this receptor on your tumors, I will treat you. Theoretically, you get better. And if you don't have the receptor, I'm not going to do it blindly. Again, we'll go back to anti-androgen drugs. I'm going to assume that the patient, all his tumors are just androgen sensitive, give him the drug, come back in 6 months and see what's happening. That's kind of the old way. This is how we should be doing this, whether it's blood markers or imaging markers, but that should be the new way of business, but it's not. So that is radiotheranostics, where we're using the same therapy agent, usually with an isotope, an alpha or beta or a combination. Is this a new concept? No. So since 1930, again, Memorial Sloan Kettering, I tend to hate this place because they're so successful, started giving radioactive iodine for thyroid disease. I think it only got approved in 1952 by the FDA. So this concept of seeing what you treat and treat what you see as another buzzword is not new. So here's a patient that had some things. He had a thyroidectomy. We can see nodes in his neck. We treated with him radioactive iodine, and he's cured. It's been around for a while, but because of prostate cancer, because of the large market share, it's getting buzz. But at the moment, I'm on trials with pancreatic, melanoma, glioblastoma, actually small cell lung cancer, non-small lung cancer. There isn't a cancer that some company isn't thinking of a solution to, as well as other solutions. So it's kind of a new concept. So when did the change happen? So probably the radium, which didn't work very well, and we're very glad to get rid of it, for people with metastatic bone disease. That happened in 2013, that we started giving alpha particles for people with metastatic bone disease and prostate. That wasn't much of a revolution, but that brought in about lots of dollars in investment funds that then translated later into the neuroendocrine revolution that happened in 2017. And mainly from the Australian group and someone from New Orleans, if anybody knew Oliver Sartor, there we go, who had to go to Australia to learn how to do this. God knows why. But this revolution just happened in 2021. And I think we're on our 600th patient already, and it's 2025. So this is really happening. So just a question, how many patients are you treating? Is this a common procedure here in New Orleans?
On Roosevelt, maybe 80 days per year, about two.
So you've only scratched at the very surface of what's available here. I would expect Novartis to come and invest heavily. Yeah. Okay, and what are the pictures? So here's a patient with metastatic bone disease. These little black blips that shouldn't be there, you treat them with active radium, and then it switches off, and there's no more new bone developing around it. Here's a person with metastatic neuroendocrine cancer. We did imaging with gallium dotatate. I switched out the gallium to lutetium-177, and most of the lesions disappeared. And here's a patient with a gallium PSMA for prostate cancer, lots of disease. I switched out the gallium for lutetium, and his disease got better. So these are the landmarks which are causing this huge investment and opening up this field, which I didn't think would be around 5 to 6 years ago. And I'm very happy. I'm definitely not retiring at the moment while this is going on. Okay. So is it good enough? The fact that I have 2 agents, should I sit back in my easy chair and say, we're doing great? And these agents have been approved, so all your patients can get them. Am I feeling at all satisfied? Or actually, the more I do, I understand that it's not good enough. That just like the initial success we found with immune agents, yeah, they're really amazing in 20%, but what do we do for the other 80%? We hold them hands and say, oh, I'm so sorry, you're not lucky. So can we do better? Yes, we can do better. So how can we do better? So the Australians, again, I would say, apart from Memorial Sloan Kettering, maybe the Australians annoy me as well. They're doing such good studies, have done great studies that, surprisingly enough, we know from radonc and physics, if you can target the tumor with a higher dose, surprise, surprise, you can actually treat it better. So the current regimen is not individualized. It's KISS, keep it simple, stupid. Everybody gets 200 millicuries once every 6 weeks. We don't assess really what's going after dose. We don't know if that dose is toxic to your kidneys or not, unless it takes 2 years to actually see a change. It's not immediate. And everybody gets 200 and we clap them on the back and the hospital says, can you increase your turnover and throughput? That's probably not the way to do it. The way to do it is we're now taking a picture after each administration of the therapy, looking at the efficacy dose versus the toxicity dose, and modifying the next dose so we can do better targeting. That's probably where we should be, but it could take a while before this diffuses throughout the country. So that's where we should be. That's our goal. We're doing well, but we need to do better. How do we do better? Personalized therapy. And you could take this to oncology. When do you actually sample the patient's tumor? The difference between carpet bombing chemo and specific targeted molecular therapies, it's a similar type change. Is it scalable? Is it economic? Probably, but it's a bit challenging to do. So this is a study that came out this year from the West Coast, I think the San Francisco group. What happens when you image after each dose of PSMA? When do you change your mind? So I went there 2 years ago because we were going to go buy one of the new scanners. And I was chatting, well, why do I want to buy this $1 million scanner when I can, my regular $250,000 scanner works well? And basically the answer I got was, well, you don't know what you're going to find until you actually do it. So I'm quite happy they got the scanner free. And 57% of people did not get the 6 therapies. They stopped early. So at least you didn't harm 43% needlessly. Yes, the hospital didn't make the money, but you didn't do it. So I can see earlier if you have a great response early, maybe you don't need 6 therapies. I'll bank them for later. If you're progressing on therapy 2, we may as well give up and move to a different trial as soon as possible. Why would I delay it by 6 months? Just so I can get all my therapies in and pay for the new building they're building for me? Perhaps, but, and we can see here, if we used modulation, which we learned from radiation oncology, the same concepts, we can get much better outcomes. If you've progressed on one of these scans, we may as well stop treating you immediately. So that's where we're aiming for. Unfortunately, the newer scanners are important. I only have 2 of them, and at 6 patients a day, that's 7 hours of scan time. And if you don't have 3 or 4 scanners, you won't be able to do your regular heart work or whatever your scanners do. So it's some logistics involved, but once you've got it, you actually feel that you're providing value, that I'm not sure we're providing that value at the moment. Is there a time clock? I can't see. There's no clock. How long have I got? Okay, great. What else are we not doing right? Probably nobody apart from me. This is a very nice graph. There's another 2 Australian people that I relatively worship, especially this guy Hicks, who came up for something very simple that even a radiologist, oncologist, or radonc can actually understand. It's a traffic light method. So this is a patient that we're thinking of giving a Lutathera, let's say he has metastatic neuroendocrine tumor. We do a PET scan with FDG. We do a PET scan with somatostatin, a Luta or a dotatate scan. If we see that the lesion is only hot on the dotatate scan, that would be green. That means I can treat you, but I don't think any of these lesions are going to be the driver of your mortality. Perhaps it will have an impact on outcome in 5 to 6 years, just like we like treating follicular cancer so it won't do a malignant transformation to a large B cell, but I'm not sure of the urgency. If the lesions are only positive with FDG, there is no reason to treat you anyway. I'm not going to be helping you. And the sweet spot is actually in the orange, where you're positive on both, because these are probably going to be the aggressive tumors, which will benefit from more aggressive therapy. And the more they're FDG avid, I'm going to add, if this was neuroendocrine, I would give them CAP-10. If this was prostate, I might give a bispecific antibody. I know that my radiation, I know that the regular therapy is not going to be enough. And if I don't modify my treatment, I've done nothing. I've known that I should do better, and I'm not doing better. And if we look at outcomes, so this is a very busy slide, I apologize. But I like these waterfall plots. They confuse me for a while, but you can see everybody that when it's going under, that means everybody had a good PSA response. When it's 50-50, I don't know why we treat them. And when it's 70-30, I definitely don't know why I treat anybody. So this is the Australian impact on who had a PSA decrease when they used the traffic light system to decide, is it a heterogeneous tumor, which there's no point treating them with standard, do we need to modify it? And then here's the American experience and the European, where they just get one type of PET scan, which doesn't give you the whole picture of heterogeneity. And then they kind of repeated, this is a graph where they did it on neuroendocrine patients, doing FDG and somatostatin, the difference in outcomes, and it just repeats itself again and again. Ask me if an insurance company in America would save money by ordering and mandating that every prostate cancer, every neuroendocrine would have an FDG scan, and that would need a SPECT scan after each therapy. They would make huge amounts of money. I spend a lot of my day on peer-to-peers trying to explain that to insurance companies and why they should pay for the FDG scan. And like most doctors, we kind of give up after a while. And I'm trying to tell them that if I only give them 2 therapies, which are not helping, versus 6 therapies, they save $420,000 for the cost of a 1,000 scan. But it's a very hard discussion if anybody else does peer-to-peers. I never get to the right person in charge of the right decision. They just read a NCNN guideline from 10 years ago, and I find it tiresome. But this is the impact if we were to do this. Okay. Am I doing well? No, I'm still not doing well. I've still got loads of patients that I've persuaded them there's this wonder drug, and nobody looks at the wonder drug is only 20 to 40% effective. What do we do with the 60% of metastatic prostate cancers? So people have moved to a different therapy, to alpha therapies, where you see this little word actinium, which has a different, it's more effective. The lethality is much, much higher than a beta emitter, and you can get great results. So up to now, I've been sending everybody to South Africa or India. If you fail my trial, here's the address, go to Mumbai, and I can get you treated for 40 grand a pop. This is your only hope. And I have to send you to South Africa. These are 2 countries that took out the enriched uranium, which I don't recommend anyone to do, to get an actinium source. Well, that's great. I'm glad that we can sacrifice people. But like America isn't willing to get rid of its nuclear deterrent, pull out the actinium from its enriched uranium. So we've had a problem for about 5 years. So the past 5 years, if you've failed lutetium or for prostate, I've sent you to either India or South Africa for their trials. But now, because of these 2, I'm not a physicist. These are fancy machines. They make alpha therapies. Now, Indiana has more alpha therapies than both India and South Africa combined when they finally get certified. And these are the trials which are available. Again, you'd probably have to be at MSK. So out of this 26 trials, I only have 6 available, but I don't have to send people anymore to India or Germany or other places to get their therapies. We can do it in Indiana, which has changed. And it used to be just actinium. Now we have leads, thorium, terbium, all these elements I never knew existed, but they seem to be pretty useful. You just have to have a LINAC or whatever that thing is called. A Rhodotron. I have no idea what it does. It's magic. It just makes stuff that I need. So that's pretty good. So there is a therapy. What else do we need to do? Have we got, can we do antibody imaging? Does anybody remember when we used to do antibody imaging? Probably nobody in this. We used to do really crappy antibody imaging that I was so embarrassed about. We did it. Anybody remember Prostacint? No, nobody does. It was crap. You inject it, you wait 5 days, you take a picture, nobody can interpret it, and it got buried and died like, I don't know, flared trousers, Brill cream, shirts with two collars, and it should have been buried a long time ago. However, 3 weeks ago, we started the surge of antibody imaging, just like in therapy. Anything you can think has got a MIB, NIB, MAB on it. Now we've moved that same targeting to identifying tumors, identifying heterogeneity in tumors, and therapeutic tumors. So we're doing a trial. This is actually not a trial, it's a clinical one. I used to have to biopsy these, every single renal lesion, and give the urologist a score, a Furman score, saying how aggressive it is, and nobody liked it. People bleed. Is it an oncocytoma? Now we just use an antibody imaging called girentuximab, which is carbonic anhydrase, which is something that turns bicarbonate to CO2. And it does a pretty good job of, I think, up to 3 millimeters, I can tell you what every renal is. And here's just a case of a positive lesion. Here's a negative lesion. I don't have to biopsy it. It only shows up on aggressive tumors. And then in my left hand, I have the therapeutic alpha agent. If he's not a surgical candidate, I've got something to offer him. And if I think the alpha therapy, I've got 2 immune combinations to add to that. When I can demonstrate that the tumor sampling in the blood has reached a level that I know there's cell death, then is my time to do immune therapy, because I think it's going to work, rather than throwing it too early at a lesion. So this is kind of the future. This is my second antibody imaging. We're doing it on people with gastric cancer and breast cancer. Are they HER2 positive? Is it a homogeneous clone of, is it triple negative? Is it positive? Is it degenerated? How can I make sure that, we also have an estrogen agent, that the therapy that I'm giving is the correct therapy and the only one the patient needs? So with the use of the anti-HER2, oh, shouldn't have done that. With the use of the anti-HER2 therapies for gastric and breast, I can just tell you if it's worthwhile giving it, rather than, well, let's put the patient on the trial for 6 months, let's come back. No, I can tell you ahead of time where that's going to be a waste of time. And of course, we have 2 companies with therapeutic agents there. What is the future? I don't know what the future. If I could, I'd probably be like the guy that organizes. He's a money manager. I'm not a money manager, so I can't predict the future that well. But we started off with small molecules, receptors, PSMA, somatostatin. I've been to nanobodies with vesicles for all type of treatments. There is a lot of interest in this, and companies that should have gone defunct 10 years are being revived, because now we have a much better way of identifying targeting lesions, and with the new PET scanners and SPECT scanners of localizing them. This is my magic bullet. So this is for the money manager people who want to invest. So where do I think the future will be? This is the magic bullet. It's pre-targeting if there's anyone from industry. How does that work? I use a specific nanobody or antibody which targets my specific cancer or clone of a cancer, but I don't add the therapy, so there's no side effects to the bone marrow GI. I wait 3 days where everything not bound is excreted. Then I put my alpha therapy in, which uses this tetrazine clicket therapy that within 2 blood cycles sucks it all out of the bloodstream, so I can have high dose, high targeting, low toxicity. You're probably going to ask me, where do I sign up for the trial? I think you have to be a rat at the moment, so hopefully nobody in this audience, but there's a group in Copenhagen. The first clinical trial is starting off there, where they have 6 possible tumor targeting. But I believe this would be, if I had to invest and then not get in trouble for non-disclosures, this is where I think we can actually do some amazing stuff. And combination, hopefully we have some oncologists here. Why do I not work with an oncologist? Should I be working with an oncologist? Well, of course I should be. Why are we giving these therapies not in combination? I have no idea. It's probably to do with, I don't know, who's arguing, who will make the most amount, and it doesn't make any sense. So these are all the trials. The only combination I'm giving rotation is for aggressive neuroendocrine or small cell cancers, where we're giving both luta-dotatate or an alpha, and then depending what type of tumor, am I giving a standard CAP-10 We're not using sunitinib. I really didn't like that drug. But those we're giving for the aggressive paragangliomas neuroendocrine. A couple of trials with lutetium and radium if the majority of lesions are bone. All these are happening now and probably coming to your clinic. And here's a summary. We talked about why nuclear. We talked about theranostics versus radio theranostics, new imaging technologies, what milestones, what can we do better, personalized therapies. Out of anything here, this is what you can do tomorrow at your institution. All the rest is relatively science fiction, but this you can do tomorrow. Heterogeneity, really important. You can do this tomorrow if you like doing peer review telephones 6 or 7 times a week. Why does he need an FDG scan if he had a PSMA scan last week? It's just a pain, and I can't delegate it, so I have to do it. But alpha therapies, I don't think one's ready. None of them have hit the market yet. Next year, 2 will be available. Antibodies, we're already doing it, and any place here who has a renal cell population where they get bored of cutting out normal kidneys and causing renal failure should be interested in doing this for therapy. And combination therapy, speak to your oncologists, work together with them. It shouldn't be a separate clinic. It should be a joint clinic and working together. That's about it. Thank you. Any questions?